Thanks everybody for tuning in. This is CSHE's webinar. It's a COVID lessons learned from a dear friend of CSHE, Mary Massey. My name is Joe Brothman. I'm the Director of Facilities, EHS, and Emergency Management at UCI Health. I'm also the Orange County Chapter President, and I help out with education as the Education Chair on the CSHE board. So I get to introduce Mary for this webinar. Mary has over 25 years of hospital experience in emergency services and county health disaster management. She participates and organizes multi-agency, state, federal coalitions and deploys with CA1 DMAT and the CalMat teams, and is deployed to multiple wildfires, hurricanes, and events like Hurricane Ike, Katrina, and the Camp Fire. She's a member of the Hicks National Work Group, participated in projects with the CDC, United Nations, and numerous Homeland Security exercises across the country. She has a BSN and a public health nurse certificate, is a Department of Justice Weapons of Mass Destruction certificate, and an HCEPS instructor certification, and a master exercise practitioner. She graduated from the Naval Postgraduate School with a master's in Homeland Security and Defense, and is currently the California Hospitalization's Vice President of Emergency Management. That is a mouthful. So without further ado, I'm going to turn it over to Mary, and she's going to give us a presentation on COVID lessons learned for hospital facilities management.
Well, hello, everybody, and what an incredible job you have done. Oh my goodness, this has been a crazy few years. I remember back to the beginning, and I don't think any of us thought it would be anything like this. I remember saying to a couple friends, I thought it was going to go to August of the first year, and they all thought I was crazy. Oh my goodness, I am crazy. I mean, we all are in this business, but it has just been an amazing time. So first and foremost, I want to say thank you. The stories I've heard are just amazing. And for those who don't know me, I'm an old ER trauma nurse, McNurse, and all this. So I've been in the line of fire for many years too. So first I wanted to go ahead with the looking at our overall of the government partners. I'm not sure if everybody is aware of the different groups that came together, but we're divided into the 10 health and human services categories. We are Region 9, which goes Arizona out to Guam. So we learned how important it was working with not only our California regions, but our national regions as things got taken over and out of our control in things. So just knowing there was this part. And then if you look at the one that looks like a quilt, those are our healthcare coalitions. And if you can tell, California has more than anybody in the numbers of healthcare coalitions. And we're divided up into so many. In Southern California, it's pretty much by county. Some of the Northern California areas, it's so rural that some of the counties go together to make the healthcare coalitions. And the sharing I saw these past few years, it used to be you shared within a system or the people you knew, but boy, this was system to system, system to individuals, sharing everything they could, and just the communication was amazing. So thank you for all you did on that. Another one with the private and government coordination incident command system. Hospitals are used to using HICS, Hospital Incident Command System, that was specially designed for hospitals from the original incident command system. But we found how we had to interact with all our partners, all the government partners were having to use the incident command system. And one of the reasons, in addition to having a better response, that I think everybody's learning now, is on the reimbursement side. When you're asking FEMA for reimbursement, you have to show you weren't doing daily operations. And so this showed when you have activated Hospital Incident Command System, HICS, then you are not doing daily operations, because that's what the whole purpose of that is to step in when our daily operations don't work. So just know this was a way we could talk with everybody, and these basics we have listed here, all of the groups have. So whether it's the public information officer, I can call law enforcement, I can call public health, I can call whichever group I'm trying to deal with, not only during COVID, but during normal times. And so we can talk to those when we don't know the name of who's on response, because this was a 24-hour-a-day one. Communication. Do you remember back, I know this is a long time ago, we didn't know. We didn't know how it transmitted. Think of your jobs then. You were having to set up all these different things, guessing what is the way that we need to protect on this? What's going on here that we need to make a difference on, because we don't know. Is it touching surfaces? Is it respiratory? Is it whatever? We didn't know what kind of personal protective equipment we needed. We didn't have any treatments. It was, wow, amazing. So many unknowns went on during all of this. We're learning, and as we've learned, everything seems to change. So we're having some very interesting things, and it showed how important the communication that we had set up was. Because if we wouldn't have had the communication we had set up and worked, I don't know how many you remember what is it now, 13 years ago, when we had what we thought was pandemic flu, the communication was pretty bad. I would have two phones to my head, and one would be state EMS telling me to do one specific thing. One would be state public health telling me to do another. And then I'd get on another call with CDC who would tell me to do something different. We've worked well on that, but it's not perfect yet. We've had so many changes. We've learned more about the virus, and the caseloads fluctuated, the regulatory changes, how you've had to deal with the waivers, what can I do? And looking at next month, there's so many of the waivers are going to end at the end of the month, with you're having to deal with your alternate care sites, all the different things. Remember when we couldn't have visitors, and then we did, and then staff and how we handle them and what are the requirements. Moving all of your cafeteria furniture apart, pulling out, I saw some places where all the break rooms, they'd have to pull the furniture out because otherwise people were taking off their masks. All the things that you guys had to deal with. Testing for staff before your staff could even get to your departments, the things they'd have to do, and the grant requirements. PPE, when we didn't even have it sometimes, what we had to learn to reuse and all those things. It was quite a time. And then not only the changing requirements, but the ununified requirements. And we're trying to deal with Cal OSHA right now, with CDPH, trying to align what they're saying we need to do is quite an interesting one, because it's hard when you have a group come out checking their own, but their others aren't being met, and I'm going to get in trouble one way or the other because I can't do them all at once. So that can be a really hard one to figure out how we're going to handle. And we've been trying to work with these different government agencies. We've been trying to get them together on the phone to agree on things. We've tried, there's been a weekly call that I know several of the facilities have been on every Tuesday morning at 8 o'clock for the last 2 years. And CDPH tells us what their latest requirements are. And we've been trying to get OSHPA and all of the Cal OSHA and the different groups to get on with us so that we're getting the same messaging, which can make such a difference. Because when we're getting the different messaging, it is so hard to deal with. And I have a feeling every one of you at least has one, probably 20 stories on this one. Information technology. How we've had to increase this with our meetings, so many on Zoom or Teams or whichever one. I've kind of learned, it's taken me forever. I still hesitate on getting on and off mute at times. You'd think an old dog would learn occasionally, but how much we've learned in having to do that and what our bandwidth is and how we can get together when we're not driving at $6 a gallon for gas and things like that. Telemedicine, that was a huge change in how we're doing things. From, we didn't have to increase those alternate care sites as much because they were able to do so much telemedicine. Education and grand rounds, I've seen that switched. The no visitor policies, how this way that our patients can actually have some interaction when we had that no visitor policy. Boy, that was a hard one. I think of so many people, that was the last time they'd see when they would drop off their relatives or friends. And so many died that they were never able to see in person again. And there was so much to that one. Cyber, whole different thing. I just finished a project with the White House that we've made up a checklist, a cyber checklist. You know how we've seemed to really put a lot into don't open those emails. Be really careful with that. But our big thing we have to do now is what do you do once it was open and once you've been hit by cyber terrorism? What should you have as first steps? So there are a few out there. We just did one specific for hospitals. So feel free to use that one. If you haven't got it, I can send it out to you. We put it out on several forms that can be there because it is such a big issue. We're also, I'm looking on it, working on another national effort with biomed and cyber and how they are trying to hit our different processes we use, looking at not only the cardiac monitors, but the pacemakers, the LVADs, the different things we use. There's a hospital on the East Coast a few years ago that got hit. Every IV pump, the heparin drips, all of their communication. We learned that a lot of the young nurses don't know how to write. They don't know how to do handwriting on paper forms. And so we've done a lot of downtime on night shifts. And so we find much of the day shift has no idea how to do downtime because they haven't practiced with it. So make sure that's going on and maybe take a look at this when we come out with the new biomed things, because it really is a threat. We're really worried with what's going on in the Ukraine with Russia right now, because that is the area where a lot of our hits come from. And so that's why we ramped up for the first one, and then we're ramping up on this one to make sure. So keep up to date, be part of the different groups if you're not already. Talk with your IT departments. I know one of the big things is we speak different languages. IT and disaster both speak a different one. So try to come together on how you handle that when you're talking with them. So make sure you have those. How do I talk to you 24 hours a day when something happens and connect? What are my backups for if my instruments, my machines go down, if they're hit with some kind of cyber stoppage? So that's one of those big ones that I hate to even think about. Another one, wow, 20 hours a day on this one the first year. It was pretty amazing. Allocation of scarce resources. We had all the planning in place for sharing equipment, supplies, staffing, and beds and pharmaceutical, but we hadn't planned for when we need it at the same time. I remember years ago, gosh, this is probably 10 years ago, we did an exercise in Orange County where we told the companies, I think it was Bergen and there's one other, we said, we're all of our hospitals are going to ask for the same things. We have 10 things we're going to ask for on the same day. No problem. Great. We're set. No problem. And the exercise came and it just shocked them, and they were like, no, we're just in time. We can't fill everybody's thing in one day like that. It doesn't work. So sometimes when you have things in writing, you need to test them, because they don't always think through what you're talking about. So we really learned this worldwide. I don't know if any of you are dealing with the contrast media shortage right now. 60% of the world's supply of contrast media for GE has their plant in Shanghai. It is shut down. It was down to 10%, but now of production, but now it's down to shut down. And so we're trying to figure out what's the answer to this. We've been meeting state and national levels on that one. And so all those different supply issues. It was very interesting at the beginning how we didn't understand how to handle this big of a thing. And we have the strategic national stockpile called the SNS that they'd put together was pretty much 9/11 type supplies. We had always thought when we have a big event, it's going to be more of a trauma related event. And so we have things for wounds and major injuries, but we didn't have things in there for a public health emergency like this was with a contagious disease. Since then, we've met and we changed what's in the strategic national stockpile now, and we increased the numbers. So I think you will find quite a few N95s in there compared to what we had before. Now, one of the problems with that, this was or like a year ago when we started increasing the things there. And my 2 cents to them when we would talk was, please wait till we have the production has increased and we have enough to fill the requests of all these things before you start taking them and hospitals still can't get them. And their response was, no, we want to be in control of it when there's not enough. And so we learned a lot about the control. They put in the Defense Production Act. And I don't know if you were aware of this in the middle, but they took over just with, we'll go with N95s right now, just with those, they took over 50% of the daily production from like 3M, all the producers. And so they took it and that was theirs to distribute. The other 50, the company could send to the people who already had orders in, but as you know, sometimes that meant it was a month later, 2 months later, a lot longer than what you needed. The Defense Production Act, as I put on here, it gives a lot of authority over the production. And it's not only for times of war, but domestic emergency preparedness and recovery from natural disasters, and authorizes the president to require companies to provide, to prioritize the government. So the things they're taking first, so then that they could control them. And this was another thing when we had discussions, they'd seemed to me, and this is personal opinion, to be giving more to the Eastern US. And if you've done much with DC, we're kind of on the West Coast, more of an afterthought. And it seemed to me in reality that was happening during a real emergency. So we really got our voices out there to say, oh, and they started listening and evened it out a little bit more. So it was a very interesting part to have this put into our requirement. And then entering the data points, oh my goodness. They asked the states, in order to get this, each facility had to put the data points in. Well, CDPH, California Department of Public Health, worked on this, but they had way more than 72 and they weren't able to get it out fast enough to get it. So they asked us at CSHE, California Hospital Association, if we would work on it. So we've had a whole department working on that for 2 years to get them the data daily from you. And what an incredible job, including weekends. This week on that weekly call, it's been asked for a few months now. It's like, please, do we really need it on weekends right now and holidays? Because they have to, some of the facilities don't have the people that do this data entry there on weekends and holidays and are having to bring them in because it is a huge deal. Not just one person can do it. So then that's what they would base what we had. So we really had to show how we could work together on this and getting the data that they required in order to move forward with that. So not a fun one, but boy, we've learned a lot. Alternate care sites. Wow. The infection control considerations, because we didn't know at times, how is this spreading? How do we do this? Staff areas, like I said, I saw many places take all the seating out of the rest areas because staff were going in, sitting and taking their masks off, and it was spreading. And boy, this was in the early days. As it's got to now, it's the Omicron BA.2. It spreads so easily. Each version has spread so much faster, the variant, not version, but it's really interesting to look at. In the toilets, hand washing, food service, pharmacy access, heating and cooling. You know, we have tested our tents in exercises and things, but we've never tested them for a couple years. The tents we've had, we've learned we need bigger ones. We need stronger ones. We need ones that can live through some of the crazy things that we've done weather-wise, which I know California weather is much different than if we were like in upstate New York or the Midwest or hurricane areas or tornado alley or things, but it's still, our tents were not set to put up with, especially the Santa Anas. Location. Be prepared for the wind and rain. I don't know what different ideas, if you want to put them into the chat, that you use to hold your tents down. I've seen use of big water containers. I've seen sandbags. I've seen K-rails. If you're using the K-rails, remember to if you're using water ones, refill them with water. It does go out. We're so used to not having to do it because we have these short-term uses of them. So take a look. Also, make sure you're notifying your licensing and certification locally, because I have seen it the minute it shows up on the news, they're out there. And it's much better to tell your MOAC, your medical health or operational area coordinator for your county, and the local licensing and cert people ahead of time. They seem more understanding, I've seen historically, than if you don't tell them. So make sure you tell that. Rain. What are you going to do with the rain? Are you closing down your windows? Do you have leakage? Have you tried running a hose up top to see if it leaks if the rain comes? Do I need secondary coverage on top? What are some of my ideas when I have leaks, when the wind is blowing? I've had a few lift and move. I had one with people in it that moved. No, I won't tell you what hospital. But there's been some very interesting things that have happened with wind and rain over the last 2 years. So when you're looking at them, look at some of these things. What are some of the ways that I can hold it down? Ask around, see, what did you think of it? What did you hear? Multidisciplinary team beforehand, not when it's an emergency. Obviously, it's an emergency if you have to set it up. Looking at the infrastructure, what do you need? You are going to be so helpful in this. Make sure you are on the team. You are the most important part. So you're looking at what are all the parts? If possible, I've heard from different places, standardize if you have a multi-facility system where possible. It makes a huge difference. One of the things I heard from one system is, if possible, put it in the first floor of a parking garage if you have one. It helped with the location so much more because they don't have the problems as much with the wind and rain. It's still there. You still have some water that's going to be pooling in places, but do what you can. And if you put up berms, how are you going to handle if you have somebody in wheelchairs, gurneys? Just make sure you're looking at all those answers when you're putting them together. Make sure the emergency department is part of this. And how, if a patient goes bad, are they going to be transported from that area to the hospital itself? What's the way that you're going to do it? And if you have a contagious disease like this one, how is that transport going to go? Which doorways are you going to use? Make sure you have this all scheduled out ahead of time. And it won't only be this one. You know, we're going to have some future fun with other things. IT and IS. How are you going to use heart monitors if you need them? How are you going to do charting? How are you going to do registration? So what are the connections on that you need? What are the different parts to each of the pieces? What are the hookups? Biomedical. Add some more rounds here. What's the equipment I need to have out there? EVS. How are we going to add this to their rounds too? Not only bringing us the clean, but taking away the dirty. And depending on what the agent or variant is, do I need to have it in just this regular waste, or do I need to look at something I need to handle specially? Pharmacy, what medications are going to be stored out there? Is this a tent that's just used for vaccines? Is it one that's used for treatment areas? So have them be part of this with your planning. And security. Security is a big one. I've seen a lot of things stolen. People shared with themselves here, even staff. So make sure you have things done in a way that you can keep them as secure as possible. I'm pretty sure every facility lost quite a few N95s, which I feel a little different on that one than most things, because I'd rather staff be safe everywhere instead of catching it someplace else. But we do have to be pretty careful with some of those things. Parts and accessory checklists with tents. One of the health systems actually came up with a part and accessory checklist for their tent, because they found they lost things and they didn't know once it was set up what you needed to put down back together to make sure it was there, because a few things would get lost each time. So they made a checklist that you could use putting together, and then when you demob, you can look at that checklist of what needs to go back in, and you can say, okay, I'm missing that, because I know something's going to be missing. You can say, here are the parts I'm missing, because I would rather know now than during the next emergency when you can't get anything. Remember when you were going to Home Depot to try to get an N95? Those were interesting times. The hookups, talked about the HVAC systems that are needed out there. I was talking with one group, and they had gotten upgraded HVACs, but it didn't work with any of their electrical hookups. So they had to change it all over. So make sure when you're looking at what you're using, you have those hookups that really can help and make a difference, instead of right then and there trying to do it. Same with water. We looked at this when we had loss of water, and they'll bring in like the water buffaloes and the different type of water to bring us, but we have to connect with them. So make sure you have the connectors that can get those things you need. Medical gases, how are you going to handle that? The problems you saw, I'll bet there's been some interesting stories on this one too. I remember about a year ago when our systems were having to be so overloaded with the oxygen delivery systems that we'd never had before. They were freezing up. There were all kinds of problems. So make sure that you're looking at how you would handle this if you have really high needs. The other thing with the electrical is make sure that your emergency things that need electrical are connected to the red plugs. We had a trauma center. We've had a couple of hospitals that had to close for the specialty services because their CT scan was not hooked up for the emergency electrical. And we had highway patrol work with us to get the special generators in that could provide enough for them. So look at these things ahead of time. It's a whole lot better. And when you're set up, this is what I said already, with 1 amp setting and ended up with higher, but not the right hookup. So all of these, look at the hookups. Water, we have to have the hand washing, we have the toilets, we have all these different parts. Look at, is your water stagnant? What do you have to do? What are the parts? Talk with public health beforehand and get them to let you know what is needed to be done with that. Fire extinguishers, posted exit signs. One of the facilities was laughing. It wasn't that big of a tent. It was like a 12-man tent, but we had to have a posted exit sign when pretty much from any bed, any position in there, even the floor, you could see the exit, but have to have those. So much better to do this now than to wait till later. Wi-Fi. How are we going to set up the Wi-Fi? Really need it. Makes a huge difference. If possible for the cell phones too, so that you can communicate with cell phones, not only the phones you brought out. And look at your voice over internet phones. I found hospitals that have only maybe 2 landlines left in the hospital. So look and make sure you have some landline phones. Usually the red phone, paramedic phone is, well, it is a red landline phone, but look at some others so you have in places that have to have it. And your department would be one. If internet's down, you need to have a landline so you can communicate. You are the life safety for all of us. So look at that one. I've been in command centers for counties that converted all to VoIP because it does save you money. But then when they're all loaded in an emergency, the whole system goes down. So that little bit of money saved is not worth it. Computers. What kind of computers are you going to use? What kind of power to get to those and things? So be sure you're working with your IT department so you know what their needs are going to be and you can work together. And K-rails, those have been very helpful with the tents. Personnel, your own staff or your staff's family exposure, positive COVID. It's really hard. Burnout. We all seem culturally, we love to jump in a disaster. We love to help. But there is a point where we need a rest. And I'm just as bad as everybody. It's like, I want to keep going till it's done, but you really need a rest. So beforehand, don't do it during the emergency because we're really bad then. Ahead of time, look at who can relieve you. Who needs to know all these things? So if you're not there or you need a little bit of time off so that you can come back and be working back at normal speed, you have to have somebody set up to come in for you. And do that for all your staff. Who's going to be the replacement? Who's going to be here? And then while you're doing that, you can also use that with developing work lists of what is done. And I see LA County doing this with all of their facilities, and it's absolutely wonderful so that there is a list that explains what you do. And you have those teams that are coming in, the government medical teams, CalMat, California Medical Assistance Teams, the disaster medical assistance teams, those are the Health and Human Services federal ones. I'm on both of those two, and I've worked with the military teams that come in. It can be really amazing working with military. As long as you're giving them direction, they are so used to. When I was up at the campfire in Paradise, I had 1,200 in the teams of military and then CalMat, DMAT, and a couple of hospital teams from Stanford and Scripps and Kaiser. And it's just amazing how they all work together. And before that, I was used to working at the hurricanes with the groups, the federal groups and the military groups, and they really are quite helpful in it all. So look beforehand again, how am I going to do it when these people come in? And then students. One of the answers we got was how we're going to use students to do some of these projects. But again, this is the time when we're looking at all this of how we're going to handle it. Psychological impacts. Fear and anxiety about the unknown. We didn't know what was going to happen at the beginning, and we don't know what's going to happen tomorrow with the next variant and all those things. And not only that, but what's the next disease that's going to pop up? Social distancing makes people feel isolated. And so being able to remove our masks and get closer at the same time while not totally protected, or some like to wear their masks, some refuse, it kind of has a lot of psychological impact. They increase stress, fear of job loss. Do you remember the beginning when people were being laid off because they closed down so many services in a hospital? That was a hard one, not knowing, and then begging to come back. We need you, we need you. So it's been quite an up and down with the psychological impacts of all of this. Some of the things we can do is communicate. I know we're supposed to be heroes and none of this affects us. It does. Communicate. Each of your facilities has a line that you can call for free and talk about this. And it is available to you. Use it if you need it. There's certain things you can do to just take a breath and try to think of something good for a few minutes. Everyone was in an unusual situation with limited resources. You want to identify and accept the things we don't have control over. And that's a hard one for me too. I try, because this is a hard one, and you could not do everything. You couldn't get so many of the things you needed. Everybody was doing the best they could with what was available. And I've never seen so many thinking outside of the box. And the things that we tried to get shared out there, because the solutions they were coming up with, not only in one county, not only just in our state or a region, but the whole United States was trying to work together. We were on so many calls trying to find out and then share what we could. So thank you for all those ideas you came up with. A big one I saw, where I saw a lot of facilities sharing, was fatality management. After 9/11, we all worked hard. We thought we had it set. Oh man, I worked with the state fatality management group. I had local coroners have presentations, tabletops, where we figure out how we're going to handle this. And boy, were we overwhelmed. We want to make sure we're coordinating with law enforcement, healthcare, emergency management, medical examiner, coroner. Each county, it's different whether they're called a medical examiner or a coroner. And one of the interesting things I found, we were in a tabletop several years ago in Orange County with the coroner, and they came in and they said, our expectation was at the hospital, we'll be first to have the coroner come and pick up all the dead bodies. And they said, oh no, you're the last. And we're like, hey, wait, we should be first. Their reasoning was, if you have your mother dead on the couch in your living room, they don't know how to handle that. And the coroner needs to go there first. Or if we have people dead out on the streets, the sidewalks, they're going to go first. And you know what? That made sense. So we worked together on how this would be handled. So that's where you need to learn, what are the expectations of the others? Okay, what happened here with COVID? Why did we have such a problem? We have this wonderful state plan. It wasn't activated. COVID is not well, if I get it, I'll tell you that one. But COVID is not a coroner problem. COVID was not a coroner's case or medical examiner's case. They were seen at the hospital. It was a disease. Yep, we know what this is. We don't have to do autopsies on it or anything. So they pushed it towards just dealing it as a routine death. There were hospitals. It was very interesting. Northern California did not get hit the same way as Southern California did. Later on, they got a little bit, but nothing like Southern California. I had hospitals with 50 to 100 dead people out back, sometimes their own staff in body bags. And going back a slide, think of what that did psychologically. I mean, that is so hard. So we talked with the state, talked to them, said, do you know this is going on? And have you activated yet? And they hadn't. So that's when they did. That's when you saw huge transport of refrigerator trucks down to Southern California. They increased the coroner's parking lot into a place to put the remains. They started doing this. So just know there are plans. Sometimes they don't get activated. So we need to know. Tracking, transportation, storage, disposal of human remains and personal effects. So there's so much with that. Facilitating access to behavioral services for the family and responders. I mean, what if when it's your own colleague? Culturally sensitive. How long do some of the cultures have before they need to be buried? This was so hard. So this is where you want to work with your community groups and see what can be done to make sure you're meeting these needs of the facility. And just the security that's having to be provided. It's pretty amazing. And to be in this position, we are already totally short-staffed throughout. And then now we're having to do the coroners and other people's jobs in order to have this be taken care of. So yeah, this was a very hard one. So plans should include training and use incident command system, because that's part of it, and facility mortuary protocols and local emergency plans. So this is, again, like I said, you got to coordinate with everybody and see, because their response may be different. They have to overlap with local plans. And you have to, again, talk with law enforcement, fire, EMS, crisis counselors, make those relationships ahead of time. Funeral directors, the mortuaries and funeral directors were a very important part. And many counties, these groups have their own meetings. So if you can at least get a relationship going with maybe their chair or something, so you know how to communicate with these people, I found that can be really helpful. Okay, going from deaths to what we can learn about all this. The after action report improvement plan. I remember when Joint Commission used to have, oh, you have to do the 2 exercises 6 months apart. And then they added an after action report. Then they added the improvement plan. You know what? This really is a good thing to have to write an after action report. And I know CMS and all the different hospital preparedness program grants and things require these HC possible, Homeland Security exercise evaluation plans. And there's a good reason. Don't waste it. Don't do some absolutely beautiful thing that nobody will ever read. We want it short and sweet. What were the problems? What caused them? What can we do about it? And then the after action report is assigning it. I'm talking 1 sentence on the problem, then a paragraph or 2 on what happened. And then here's a list of 1 through however many things we can try to improve. Then you go to that after action, or excuse me, to the improvement plan, assign a name. And yes, it may just be the lead, but make sure it gets assigned. And seriously, they don't have to be forever long lists, just short and sweet. I find they're actually done much better that way. And no, it's not always right the first time you do it, so you may have to try a second time. And just remember some of the things we've done before with the hospital incident command system. You have to have the classes. I know it can be boring, but that way, my favorite, when we had the train wreck in Orange County with almost 200 victims, I heard so many times it felt like a drill. And that's what I want to hear. Ebola, MERS-CoV, do you remember all the things we had to learn for that? And yes, there were a couple cases in California, but not very many. But all that donning and doffing we learned, oh my goodness, that was used, especially at the beginning of this. But so many changes, so much updating. Isolation rooms, air systems. I've seen so many people on how they've learned how to do this for whole units in their hospital and things. Infectious waste disposal. I don't know if you remember at the beginning, but they were telling us it's all infectious waste. And we had to step in on several jurisdictions to say, no, here's it in writing. It is not. Max vaccine planning. We've worked a lot. I don't know if you've seen what goes on for the flu shots every year at your county, but that really is their annual test they have to do to show if we need vaccines, how we would do it to get out there with mass prophylaxis for something. Triage of infectious patients, how you've had to work to help set up different areas and divisions and things so that we don't bring one person in that infects a whole waiting room, whether it's waiting for the lab or ER or whatever. Transporting. We tested that with Ebola and things. So there's a lot we learned from these rapidly changing. From the beginning to now, we see how we've had to learn to be flexible, because there are constantly new therapies, combinations. This therapy's out this week, that new strains, new regulatory requirements, the waivers are expiring, those kind of things. So it's been amazing to watch how you guys have helped with this whole thing from start to right now. I wish I could say end. Demobilization and cleanup. When to take down the tents and alternate care sites. We've tried a few times during this, and then we got to put it back up. Then we got to take it. And then sanitation. Don't just use the sanitation robot for the inside. You got to clean, because clean and sanitation are two different things. So sweep it out first. Clean outside too, so that you both have all the gunk out, and then you can sanitize it. Check all of the parts and accessories are accountable. Make that list and use that list so you can check off that you have them. Another thing I've seen is using the wire tags on zippers of the different things you're going to put into storage, so that it's all set for the next time. And you can tell, if most people, you could tell if they've gone in and taken something out. So just know that's one of the cheap but nice ways to tell. Maybe using what you use on your crash carts with the numbering system that shows when it's been used. Last one, what an amazing job you all did. It was pretty impossible. I think if they would have told us at the beginning what we were going to be facing in these next 2 years, I think we would have all just put our hands up and tried to crawl into a hole someplace. You have done so many amazing things. I remember with mass fatality, one group learned how to use carriers and use ways that they could get the bodies where they didn't have to carry them because of all the back injuries, having to load them. Nobody had ever had to load bodies into these shelves that were put in, so they would have extra places for the decedents to be stored until they were taken by the mortuaries or funeral homes. They learned ways of putting in new floorings in the trucks when you could find a refrigerator truck, that made it easier to push the gurneys over in ways that had lifts up there. Every part of this, from tents to admissions to rooms to air, mass fatality, all these different facility type operations, they not only learned how to do, but they shared. They set it out there and said, here's what we tried. And I had so many facilities that copied all these different things. And when they couldn't find things, they would share them, or they'd tell them, hey, look on this mortuary website. They still have these parts and things. So it's just quite amazing, the different things that you all have done to help us respond, and how many lives were saved because of you. So I really want to say thank you. So now, time for questions. We'll open this up.
I see one Chris has in the chat, Mary. Is CHA working with our state and federal partners to ensure their supply caches are funded and maintained? And Chris is there waving at you too.
Oh, yes. everything that we find shortness of. I just met with the state earlier this week on the, because when we first started to find out about the contrast supplies. Anything I heard during the really acute parts of COVID, I called directly to the state, the Cal OES's command center, and talked with the logistics person. And we would either I would alert them to something's going on, see what they had. I used to, for a few months, they allowed us to see what they had in the cache, but then they couldn't keep up with it. So I'm trying to get that back again, so that if I get a request from somebody, I can look and see if it's there, if we have a lot of it. I can also see, before I was able to see as they went through it, how many they'd go through over the previous week and how many they have currently. So I'd see what the burn rate was for people not able to find something. So yes, and I've also been dealing with CDC on the SNS. I've been meeting with them for the last year and a half to try to get things into the stockpile that weren't there before, and the things that are, to get them at the correct levels.
Thank you, Mary. Appreciate it. And thanks for the presentation as well.
Oh, thank you.
Anyone else have any other questions for Mary? You could either put it into the chat, or now is your
Saw a
opportunity.
hand up. I think,
Saw a
can they
hand.
take their off mute? I saw a hand up. Let's see.
Yeah, I had my hand up and I'm off mute. Can you hear me okay?
I can.
Great. Thank you, Mary, for an excellent presentation and for the work that CHA is doing. One of the things that's a lesson that we've relearned again is that supply chain challenge when we've got a demand on PPE. And initially the way it's set up is they assign a tier so that the hospitals get it. It's very important. The challenge we had was a lot of vendors that were not necessarily hospital employees, but needed that equipment to provide support to the hospital, were unable to get it. Is CHA looking at a possibility of creating a definition for critical vendors? Like, we were doing a lot of fit testing, which meant we had to be in close contact with the walking wounded, right? And we could not get N95 respirators or face shields at all for 6 weeks.
Would you mind sending me an email with the question like that? Because I like this, and put that in, and then I can work with CHA on that one.
Perfect. Thank you.
I think that's a really good idea.
Yeah, all the hospitals, I imagine anyway, rely on our vendor and contractors to support a lot of this stuff, especially when the surge increased that demand. So it's a good point. Any other questions for Mary? Mary, thanks so much. And what a great roundup of everything that, started and then we went through, and some of the lessons learned. I imagine we could probably dive into any one of those topics for a couple hours, and we'd probably still have more to talk about. But really appreciate all the work you've done as well. You've been an instrumental part to a lot of the hospitals here to help us out, not only during COVID, but before it and after it. So appreciate your partnership, appreciate everything you've done, and thank you for everybody for tuning in. Happy Hospital Week. I get to go to a luau now and serve some food. But I hope everyone is enjoying Nurses and Hospital Week, and you can catch us again on our next webinar. So thanks, everybody. Have a good rest of your day.
Thank you all for your time.
Thank you. Good to see you, Mr. Sparks.
Thank you.